Good afternoon and welcome to the City Club of Eugene's May 9th, 2025 program, Prevention, the Heart of Public Health. My name is Andrew Kalk and I am City Club's president. We're coming to you from our home at the historic Wow Hall in the heart of downtown Eugene, and it's my pleasure to extend a warm welcome to our speakers and to all of you joining us here, in person, online, and over the radio. Since 1990, City Club has been dedicated to our founding mission to build community vision through open inquiry. In accordance with our mission and purpose, we hope to help connect people throughout our community and across generations, identities, experiences, and perspectives. You are invited this week and every week to join us in this effort, to share your wisdom, learn something new, and take active steps to make a difference in this city and region that we love. Of course, we cannot do this work alone, so a special thank you to our Platinum, Community, and Diamond sponsors. Kaiser Permanente, which exists to provide high-quality, affordable healthcare services and to improve the health of our members and the communities we serve. More information at www.kp.org. The University of Oregon has helped Oregonians question critically, think logically, reason effectively, communicate clearly, act creatively, and live ethically since 1876. More information at uoregon.edu. Lane Community College transforms lives through learning. LCC provides comprehensive, accessible, high-quality educational opportunities that promote student success. For more information, visit lanecc.edu. And thank you to the City of Eugene and to Lane County for their support as well. I'll now hand the microphone to Betsy Pownell, the coordinator of today's program and a member of City Club's program committee. Betsy.
Thank you, Andrew, and hello, everybody. Welcome. My name is Betsy Pownell. I'm a member of the program committee. I'm going to move this, I think, yeah. I'm the member of City Club. I'm a City Club member. Trust is like the air we breathe. When it's present, nobody really notices, and when it's absent, everyone notices. That quote by Warren Buffett, to me, really describes what public health has been and is in our community and in our country. Prior to the COVID pandemic, the Public Health Department was part of our scenery, always present, humming along. It was like the air we breathe. All Americans knowingly and unknowingly interacted with the Public Health Department. We took for granted our vaccine registration cards, the restaurant inspections, the warnings and advisories for potential waves of illness, etc. The list goes on. However, as our new U.S. Health and Human Services Department Secretary Robert F. Kennedy Jr. proceeds to lay off 10,000 employees from HHS, including from CDC, the FDA, National Institutes of Health, and Centers for Medicaid and Medicare Services, and as the Make America Healthy Again movement gains traction, it seems an important time to consider the role Lane County Public Health Department plays in our community and how the critical but often invisible work of prevention impacts all of us and our potential to thrive. Prevention, the heart of public health, will include Dr. Patrick Ledke, Senior Public Health Officer and Chief Medical Officer for the Lane County Department of Public Health, Jocelyn Warren, PhD, Division Manager of Lane County Public Health, Anne-Marie Mauricio, PhD, Associate Research Professor at the University of Oregon Prevention Science Institute, and Dr. Kimberly Ruscher, Chief Medical Officer for Peace Health. Together, they will illustrate the powerful potential to create healthy and thriving communities and how prevention is working here in Lane County to promote health and wellness every day. I'll turn this over to Dr. Ledke.
Good afternoon, everyone, and thank you, Betsy. I am indeed Dr. Patrick Ledke, and I am most happy to join you today, and thank you for the opportunity to do so. My gosh, it's nice to have such a big attendance. I think I'm still in COVID brain where we had no attendance for so long. It's really nice to see everyone here today. Our discussion today, as Betsy outlined, is about public health and the many roles of prevention within the structure of public health. And my role in that space is to lay out a basic infrastructure of public health, and the other speakers are going to put a good deal of details and personal experiences in the prevention space. So let's just dig right in. Public health has had many definitions over the years. The CDC, the World Health Organization, other countries have had a variety of definitions, and one of my favorite definitions comes from the Institute of Medicine, which, as many of you probably know, was renamed the National Academies of Medicine some years ago. But back in the 80s, the definition of the mission of public health was to fulfill society's interest in assuring the conditions in which people can be healthy. And some years later, the Center for Disease Control changed the definition to something even shorter that I think is very memorable and has stayed with me for 20 plus years. Healthy people in healthy communities. That is the goal of public health. And we're going to discuss that and how we get there. So at the heart of moving to healthy people and healthy communities is indeed prevention. Prevention through the lifespan, prevention across the environment, the places we live, labor, learn, and play, prevention in every space. And to ensure that that prevention happens, we have a structure around public health, including core functions and essential services. And the three core functions of public health, and I would ask everybody to raise their hand if they know them and who wants to shout them out. I didn't know them for years. I didn't even realize that public health had core functions. We just have all these programs. But the three core functions are assessment, policy development, and assurance. And in the assessment space, the goal is to systematically collect data, analyze that data, and share it with the community, everyone who could use that data in a positive, preventive way, whether it's the clinical community, the environmental community, businesses, etc. So we assess the population. There are, of course, rules and Oregon statutes that allow us to do these sort of things that help, but assessment is really a key function to give us data upon which we can act. In the policy development space, our goal is to promote the use of scientific knowledge to promote these policies and promote decision making. I suspect there are some listening today or some in the audience today that will remember when our county went through something called HIAP, Health in All Policies. We worked with the county commissioners to ensure that every policy that's implemented, whether it's spraying for weeds on our 4,000 miles of highways in Lane County or whatever it might be, includes a health component. That's a big core part of public health and a big part of prevention as well. And then finally, in the assurance space, we want to ensure the provision of services to those in need, whoever they may be, whatever their financial levels are, wherever they live geographically in our region. That's the assurance space. We also work collectively with the clinical community, making sure that there are services available to all, which, as many of you know, has become harder and harder during the pandemic, and since the pandemic, it's a challenge delivering care to all the people in need. So I want to give an example across the three levels of public health. We have local health departments, sometimes they're county, sometimes they're city. We have the state level, we have a state health department in all 50 states, and of course we have the federal initiative in the public health space, in particular in the Center for Disease Control and Prevention. And it might be useful to give you a sense of how each of those levels play and how they interlink across a specific initiative. And I'm just going to do it very briefly. Let's talk about tobacco. At the local level, we have a ordinance actually the ordinance started in Benton County in Oregon, for bars and restaurants where you can't have tobacco use. That happens at the local level. Those types of ordinances happen at the local level, working through local public health and local elected officials. At the state level in tobacco space, one initiative that many of you probably know is taxes on tobacco. How can you tax tobacco and use that revenue to decrease use and improve health, but also use the revenue in spaces that will improve health as well? And at the federal level, states and local health departments cannot, for example, prevent the use of tobacco on commercial airplanes. That is a federal level initiative. So 3 levels in public health, 3 examples in the tobacco space of how we work together to improve health. So I'm going to finish up with my introduction and talking about the levels at which we in the local public health space are active in what I call in the trenches and on the mountaintops. And I'll give you a couple examples of each. In the trenches, many of you probably don't know that there are child fatality review groups that each of the counties are required to take a deep look at every quarter, typically, looking at child fatalities and determining how it happened and how we can prevent them. That's something you don't see typically, but we work interdisciplinary with the police, with Child Protective Services, with the clinical community, the medical examiner, trying to prevent those, learn from those terrible occurrences and prevent them. We also are responsible for the disposition of human remains if somebody dies and there's no next of kin. Public health does that. We work with the funeral home, the crematorium, to dig deeply to figure out how it is that, is there a next of kin, and what we can do to ensure that the wishes of that particular person are indeed met. Now on the mountaintops, I'm just going to give an example around data. There are roughly 70 reportable diseases in Oregon. They are reported to public health. Many of them are what you would expect: hepatitis, sexually transmitted diseases, toxic shellfish poisoning, if we have toxic shellfish problems one year. Those are all reported to public health, and we get that really high perch where we get to see across the population the numbers of these diseases and the impacts. And I really think that's public health on the mountaintops. We also have a syndromic surveillance system. If you think about how public health works, if we're waiting for a disease to be tested and a laboratory to report to public health, there might be weeks between the exposure, et cetera. So sometimes we look at syndromes. If 30 people show up in Dr. Ruscher's hospital one day, we might not know the diagnosis in particular for several days, but if they all show up with fever and neurological compromise, we want to know. So we look at syndromes too, and that I think is public health way on the mountaintops as well. And then finally, preparedness and response. You wouldn't probably believe how much preparedness and response happens behind the scenes. We in public health have identified organizations and facilities where if we had a major Cascadia earthquake or an airplane crashed in downtown Eugene or Springfield, where would we triage everybody? Where we have contracts with specific spaces in the preparedness response arena. So a lot of work in that space and high level on the mountaintops views across our communities. So I'm going to stop there and pitch it to our next speaker, who is Jocelyn Warren.
Good afternoon. Thank you for having me. Thank you, Betsy, for putting this panel together. I'm Jocelyn Warren. I'm the Division Manager for Public Health in Lane County. As Dr. Lutke mentioned, prevention really is the core of all public health programs and services. That's true in services to individuals, in our policy, and in our planning. We have a number of prevention programs in specific topic areas. Pat mentioned tobacco. We also have alcohol and other drug prevention, problem gambling prevention, suicide prevention. Our immunization program limits vaccine preventable illnesses, and our environmental health program prevents foodborne illnesses. An area, though, of particular strength in Lane County Public Health is maybe not one that you are very familiar with. It's focused on the prenatal and early childhood times of lives when our services and our interventions can have really significant impacts over generations. Significant resources, including County General Fund, go to support WIC nutrition services and lactation support, and to our nurse home visiting programs. Our largest home visiting program is Nurse Family Partnership, and maybe you've heard of that. It's a national program. It has 45 years of research behind it. It's a voluntary program. Specially trained nurses regularly visit with new parents-to-be, starting early in pregnancy, which is typically earlier than 28 weeks, and continuing through the child's second birthday. So it's a long-term relationship. The goals of the program are, 1, to improve pregnancy outcomes by helping new parents engage in good preventive health practices. 2, improve child health and development by helping parents provide nurturing, responsive, and attuned care. And 3, improve the economic self-sufficiency of the family by helping parents develop a vision for their own future. The decades of research behind Nurse Family Partnership have demonstrated some really impressive and important outcomes in national research trials. So here are a few. 48% reduction in child abuse and neglect, 56% reduction in ER visits for accidents and poisonings, 50% reduction in language delays for children at age 2 months, 67% fewer behavioral and intellectual problems at age 6, 82% increase in months the parent is employed, and 59% reduction in child arrests at age 15. Lane County launched Nurse Family Partnership in 2012, and we have 7 registered nurses on the team and a nurse supervisor. We have bilingual and bicultural staff to serve Spanish-speaking clients, and we cover all of Lane County. Annually, we serve about 100 new families in Nurse Family Partnership. We do prioritize families that have social and medical risk factors that may lead to adverse outcomes later. I want to share a story of one client who gave permission for her story to be shared. Lisa worked with an NFP nurse several years ago now. As she tells it, she was in a dark place when she first learned she was pregnant. Lisa wanted a child but felt completely unprepared, especially as most of her family and friends were hundreds of miles away in Michigan. At the time, she was living with the child's father in a tiny room in his mother's apartment. Lisa's fear and uncertainty continued to grow. Lisa said she realized she could keep on living in quiet desperation and anxiety. She had struggled with depression in the past, or she could reach out for help, which is what she did. Lisa sought help and was connected with Nurse Jill, an NFP nurse in public health. At first, Lisa had all the worries you might have about a stranger, even a nurse, coming to your home. Will they judge me? Will they think I'm not capable of being a mother? So she first met Nurse Jill at the WIC office downtown, and Lisa said she couldn't believe how laid back Nurse Jill was and how easy she was to talk to. Nurse Jill and Lisa continued to meet, and Nurse Jill tailored her support specifically to Lisa's needs, including economic stability, which was Lisa's top priority. And there were setbacks along the way. An application for an affordable housing complex was denied, and Lisa asked for an emergency meeting that night with Nurse Jill, who was there to listen and encourage her to keep applying. Lisa found housing 2 weeks before her baby was due. Once her son was born, Nurse Jill was there to ease first-time mom anxieties and help her track developmental milestones. As Lisa said, so much goes into raising tiny humans. In my experience, she said, Jill adapted to what we needed. She filled in areas where we best needed help. Most of all, Lisa said Nurse Jill gave her confidence as a mother, a woman, and a student. Lisa returned to school when her son was 9 months old and is now working full-time locally as a registered nurse herself. She's Nurse Lisa, and her son is now 9 years old. Prevention programs like Nurse Family Partnership that intervene early and help to prevent the worst-case scenarios for individuals and families can also be described as public safety programs. They are at work long before the damage is done. They help put parents, kids, and families on a safer path to a better and brighter future, and multiply that by hundreds, then thousands, and that's how we not only keep a community safe, but allow everyone to thrive together. The impacts of many of our prevention programs are not felt immediately. The changes come over months, years, and even decades. That also means that the loss of these programs might not be felt immediately. That is the risk we face when making cuts to prevention and to public health. Disinvestment and dismantling of public health research, services, and infrastructure might not raise alarms right away. It might not result in immediate harm, but the impacts will be felt in the years to come in missed opportunities. Thank you. And now I'm going to pass to Anne-Marie Mauricio with the UO Prevention Science Institute.
Right away, but our definitely felt is something we're dealing with at the Prevention Science Institute is our research and our programming is being cut. I'm going to talk with you about youth mental health and what we can do to support it. To highlight how important youth mental health is, we know that suicide, substance use overdose, and violence are the 3 leading causes of adolescent mortality. What we also know is that all these are preventable by supporting adolescent mental health. We also know that interventions that promote adolescent mental health are cost effective. They save taxpayer dollars. For every $1 invested, downstream we save up to $16. These savings are about reductions in juvenile justice costs, reductions in healthcare, but also better outcomes academically and vocationally for youth. According to the National Institute of Mental Health, 50% of adolescents ages 13 to 18 have a mental health disorder, and 22% of these say they're experiencing significant impairment as a result of this disorder. So what do we do? Fortunately, there's some good news. Family-centered interventions that promote positive parenting and positive family relationships linked to positive mental health. And we have several of these interventions available to us. And this is actually the work that I do. I develop, I implement, I evaluate, and try to disseminate evidence-based parenting interventions. And I say try to disseminate because it's very hard to reach and serve the children and families who could benefit from these interventions. And why is this? Barriers. There are many barriers that impede access. Most evidence-based family-centered interventions are in person and require multiple sessions of participation. This makes it difficult to deliver these interventions. Other barriers are attitudinal, such as perceived stigma associated with accessing services. We also know that these barriers most strongly affect families who have a lot of contextual risk who most need the services. Other barriers are organizational. A lot of agencies don't have the resources, the personnel, the space to actually implement these interventions. And our mental health workforce has been dwindling, and there's high turnover, and this has significantly increased since the COVID-19 pandemic, making it very challenging to meet the needs of adolescents who need mental health services. Fortunately, we have a solution for this as well. That solution is digital health interventions. They offer an innovative approach to reach youth who need mental health services. They minimize logistical barriers such as transportation, but also because they're self-paced, self-directed, and can be accessed at parents' convenience, they also have the potential to minimize attitudinal barriers such as stigma. Digital health interventions also minimize organizational level barriers. They require many fewer resources, so they're much easier to implement. And they also facilitate implementation with fidelity. What this means is that the intervention is going to link to the outcomes we expect. And this is particularly true. Accessing self-help digital interventions is particularly prominent in this world today where self-help digital interventions are normative. So, when evaluated in research studies, we also know these interventions work. They do promote positive parenting, they do promote positive family relationships, and these changes do lead to positive mental health for youth. However, they can only have a significant public health impact if they're translated to routine practice and widely disseminated. This is where university community partnerships are key. University community partnerships play a crucial role in translating science to practice. The extent to which evidence-based interventions developed in the context of universities and supported by research are effectively implemented, sustained, and adopted in communities has very much to do with community context-specific factors. And these are rooted in the norms, the practices, the values, and the history of the community. So as a university community researcher, we very much depend on community partners to understand, based on their knowledge, expertise, and lived experience, what we need to do so that these interventions will work in their communities. Collectively, we have the power, with communities, researchers and communities together, to have a significant public health impact through implementation of evidence-based interventions. A key point, though, Betsy mentioned trust when she opened this talk, and a key point is that these relationships must be built on trust and must be built on equitable practices, such as shared decision-making. As researchers, we can't expect to know more than communities. We don't. One example of a family-centered digital health intervention is the Family Checkup Online. It was developed at the University of Oregon. It includes an app and it includes a parenting coach if parents are interested. Parents on average spend about 2 hours on the app and about 2 hours across 5 to 6 phone calls with their parenting coach. Since 2019, we have worked with over 900 families who've participated in our research and used the program. The research we've done offers strong support that the program works. It improves parenting, it improves family relationships, and these changes also then lead to youth mental health outcomes. One of the things we're particularly excited about is that among those 900 families, almost half of them live in rural communities. Rural communities have very low resources, and we're excited that we were able to serve these families. Given the strong support for the program's efficacy, I'm part of a team at the University of Oregon working to develop relationships with community partners, particularly schools and school-based health centers. We want to understand, I think that's 1 minute, sorry, 2, okay. We want to understand what is needed to more broadly disseminate the program outside the context of research. Often it's difficult to translate evidence-based practices from science to practice, and that's what we're doing. We're asking questions like, how do we reach parents of students who need mental health support? And how do we implement this program in your system with the resources you have, with the processes you have? Like, how do we make it fit your world? So these are questions we're working with school partners to ask. Our end goal is that dissemination of these low resource interventions, such as Family Checkup Online, will increase community capacity to offer effective mental health prevention to youth and families. The end game is reductions in adolescent deaths due to suicide, substance use overdose, and violence. This is important, again, because of the prevalence among of mental health disorders among youth, and that the resources and services to service these youth are dwindling. So innovative, resource-effective solutions are needed to address today's mental health crisis among youth. Thank you, and I look forward to questions. Oh, and I'm going to pass it over to Dr. Kimberly Ruscher.
Thanks so much, and thanks to the City Club for the invite. It's great to be able to speak to positive things on behalf of Peace Health. That's not always what we're invited to talk about. I'm a pediatric surgeon, and so that means I'm a surgical subspecialist, and we're not known as surgical subspecialists for being essentially focused on prevention. But there's a great history in pediatric surgery of work on prevention because C. Everett Koop, who was a well-regarded Surgeon General, was a pediatric surgeon by background. So I'm just following in Koop's footsteps, I hope, by partnering on prevention. When I was invited to come to City Club to talk about partnership in prevention, the importance of prevention, I reflected on how I've thought about prevention throughout my life. And probably my introduction to thinking about public health and prevention was when Hurricane Andrew hit Florida in the early 90s. My dad, who's a meteorologist, talked to me about health effects in the aftermath of a major storm, for example, waterborne illnesses. And I was, old enough to get that as a, late teenager. And so I go way back with thinking about prevention. But then throughout my career, when I really began to think about prevention was in my training as a surgeon, how much I dealt with in my training the need to take care of people who are injured unnecessarily, whether through motor vehicle collisions or car accidents or gunshots or other traumas. I studied some of those, and now in my role at Peace Health, I've seen my thinking on prevention continue to evolve to think about, okay, what do we need to do as a program or a hospital to deliver prevention efforts? For example, how do we make sure that we maintain vaccine access for our pediatric patients? And I just wanted to call out a couple of prevention efforts that Peace Health has partnered with several groups in the community over the last years. And I certainly think about public health, like Dr. Ludke called out, in terms of assessment, policy development, and assurance. But I also think about it across the lifespan. Of course, as a pediatric surgeon, my affinity is to kids and children, but I also have a responsibility to think about their parents, their grandparents as well. I first wanted to mention something that crosses generations called the Blue Band Initiative. This is an effort that was locally grown and implemented at our hospital where our women's health leaders identified the need to help our community partners identify women who were at high risk of a pregnancy disease called preeclampsia. There are women who, starting at about the halfway point of pregnancy and later, can have very high blood pressure and lead to a severe disorder called preeclampsia, where the moms may experience seizures, strokes, or even death. And that can lead to impacts on the baby, including premature birth, low birth weight, organ damage, and death. So how do we help people know more quickly if a woman is in your urgent care with maybe a sinus infection and you notice her blood pressure is higher than you think it should be? How do we help create those alarm bells? Or to the medics that respond to a car accident with a pregnant woman to know there's more to this. That blue band is worn 24/7 during pregnancy until 4 weeks after the baby is born. Our EMS partners have had training to know what to look for. Our urgent care partners know what to look for. And our own labor and delivery nurses and medical staff know that band means, and there's also a wallet card to go along with that. This is important because when someone's pregnant, we cannot necessarily prevent this disease. There's a lot we can do through healthy eating and lifestyle, but there's a lot we can't. So this is a great partnership to say, hey, we know this might happen. If it does happen in the course of a woman's pregnancy, how do we do as much as we can to keep her and her infant safe? Once those babies are born safely and go on to become patients that come to our pediatric or pediatric specialty clinics, another initiative I want to mention that also affects the whole family is around food insecurity. If we think about children's health, as was called out by the last two speakers, things we do in the realm of children's health have amplifying effects as those children grow into the next City Club members, the next employees, the next leaders of our community, right? So when we deal with things that are their social determinants of health, housing, childcare, food insecurity, we have lasting effects for that family. So every pediatric patient that comes to our clinics is screened for food insecurity in the home. And through partnership with Food for Lane County, we have non-perishable food kits ready to go all the time. So if a family comes to me after their surgery and they're recovering from surgery and I find out they don't have enough food in the house that they can consistently give their medicine with food, I can walk over, get a pre-made kit ready to go that has all non-perishable ingredients, including a vegan option, so that family can take home a kit to make a easy recipe for that will feed a family of 4. And the kit also has a card in it that has instructions in both English and Spanish and a resource list. So that kit becomes tonight's meal, but then it also becomes a list of resources where they can get either ready-made food or items that they can prepare themselves from other Food for Lane County resources. One of my favorite ways that illustrates we partner to do something that can create help today and tomorrow. As we continue to look into the lifespan, many of us know the effects of substance use disorder in our community. And we have moms with new babies that need help. We have young adults, middle-aged adults, older adults that suffer. One of the phone calls I took this morning as CMO was a physician who wanted to discharge their patient, and the patient had substance use disorder and needed to discharge with opiates and wanted to talk about what resources do we have for safety for those patients. And we talked about our naloxone program where patients can be discharged with a Narcan kit for free, ready to go, so that if they or their family member are experiencing signs of an overdose, they've got that kit, a great program. Other social determinants we deal with as well, I want to call out our new partnership with Everyone Village to help with unhoused patients and their families. And then a grant we gave for childcare to Tip Tap Grow, which is a performing arts preschool in the community, and that we supplied with $35,000 to expand their services through our Women of Peace grant program. I want to call out another public health aspect, which is assessment. Dr. Ludke called out the need to use data. One area where we really do a lot of data-driven prevention is around trauma and injury prevention. Riverbend is a level 2 trauma center. We take care of patients not just from Lane County, but from across the region with moderate and severe injuries. When we look at data from patients seen between 2018 and 2024, that was 13,000 patients that we saw. In that group of 13,000 patients, the average patient's male, 60% of the time, and our average age is 72. And the leading cause of injuries is falls, meaning 40% of our patients come because of a fall, and it's mostly in the bathroom, on a slippery surface, or in the yard, for example, while trying to clear off a roof or a path. Because we know that we have that injury pattern and we've seen that trend increasing, we've begun to partner with several area agencies on fall prevention efforts and teaching, telling people what's in their homes that's potentially making it more unsafe for them. And those efforts have included outreach at elder care, AARP, and with the Wyatts and other community events. Finally, I just want to close with mentioning the environment we're doing this in. I acknowledge that I feel strongly part of the role of the hospital and the community is to think about the community's health. And I'm so glad that Dr. Ludke and I feel like we can just call each other anytime when one of us has a question or is worried about something. But I also want to just mention the current state for Oregon hospitals. A new report from the Oregon Hospital Association shows that about half of Oregon hospitals are not making money, meaning not even having the money to replace broken equipment. It's one thing to, keep the doors running. It's another thing when you find out one of your endoscopes that you use to do screening colonoscopies for colon cancer needs to be replaced, and they're not cheap. You have to have a little bit of a margin to cover those things. And with tariffs, we're watching closely the cost of equipment. When we already are losing money on a large number of our patients that come to our building, and labor costs being what they are and supply costs potentially rising under tariffs, it's a challenging time. And we want to do everything we can around prevention. And it's important to us, and we will continue to prioritize those efforts and continue to be engaged in the community health. So I'm really grateful for this opportunity to talk about some of those efforts. Thanks to City Club for having me. I look forward to the discussion after the break.
Thank you all very much. We'll begin our question and answer in just a moment, but first a special thank you to our award-winning public radio station, KLCC FM 89.7, for airing City Club programs Monday nights at 7 p.m. For those listening at home or in the car right now, your household is one of several thousand tuning into City Club on KLCC, and we love that you're here. You can also find all recent City Club programs archived on KLCC, as well as on our YouTube channel and as podcasts. We'll take a brief break before returning for questions. Thank you.
Back, everybody. It's time for questions. If any audience members have any questions, please just stand up at the microphone and we'll get this started. Okay, if you could identify yourself before you ask your question, that would be great, and then our presenters will answer.
My name is Randy.
Oh, the microphone's not working. Ralph? Ralph?
Hello. I think
Is it working?
it is working.
Great, all right, excellent.
My name is Randy Prince. I have a question about prevention of infectious diseases. Going to the COVID pandemic, it took a little while before it was officially identified that that was an aerosol transmitted disease, kind of like how measles are, except that in the case of COVID, nobody was vaccinated for it, and measles they are. Then it took a little while longer for everybody to see what they needed to do in their spaces with ventilation. There were some codes came out by commission, and newspapers had it out. But personally, even after that came out, I did not find there was very good enforcement of indoor air quality to prevent a aerosol transmitted disease. At my workplace, when the air conditioning was broken, I called federal OSHA, I called Lane County Health. Nobody really had a protocol. And even when the air conditioning guys finally came, they didn't know how to set it for the right number of changes of air per hour, this technical part. Some did. Well, you know, it's not that hard to get an idea, and I just wonder who's doing it. I mean, carbon dioxide you can measure fairly easily. It's a proxy for the hazard. Who is going to take care of this before the next disease that we don't have a vaccine for comes along? The people who operate the public spaces and just people at home who want to know, is their house safe as far as the air?
Okay, who'd like to take that?
I am happy to start, but probably not finish with a reply. And I'll start with just a bit of a preamble that when this virus showed up, SARS-CoV-2, we knew nothing about it, but there was a general sense that it was probably similar in transmission to SARS-CoV-1. Many of you will remember in 2003, SARS-CoV-1 happened, spread across the planet. There were about 800 deaths, about 8,000 cases, and there was no transmission or very little transmission until people were very sick. So the initial recommendation with SARS-CoV-2 was to follow SARS-CoV-1. It's a similar coronavirus, roughly 85% similarity. Well, it turned out not to be the case. There's a lot of non-symptomatic transmission with SARS-CoV-2. That changed everything. We didn't know that for the first few months. So once you learn more of the specifics of the virus, then you start to tailor what you're going to do with regards to response. Social distancing, wearing a mask, et cetera. Do you wear a mask only when you're in a public space? Do you wear a mask in other spaces? Now, in terms of overall ventilation, there is some aerosol transmission, but it's mostly droplet. Those are kind of specific areas where we talk about how things are transmitted. Most of it is droplet, larger droplets that fall within about 6 feet of the breathing zone. But there is some aerosol that can float in the air for a little bit and go 25 feet away. But that's not the predominant most of the time. So there are limitations what you can do. People breathe. Adults breathe 12 to 15 times a minute. They're not going to stop breathing. And you can't stop everything. So with regards to assessments, who has jurisdiction? And this was a big issue during COVID. There's the business community with OSHA. There are schools. There's the medical space. There's jurisdictional changes everywhere, and they all have to be lined up. And I do not pretend to have the solution other than to say it's quite complicated, and yes, indeed, we can all get better.
Anybody else?
It's hard to follow that, but I would mention from the hospital perspective, the other air quality concern that we have almost every year now is when the wildfire smoke is impacting our air quality. And we have great partnerships with getting data from the county and state on that so that we know, and we have a trigger-based system on what we're doing within the hospital, because we certainly have fragile patients from 0 days old to 90 years old that we want to protect from adverse exposures. And then with regards to infections, I think there were some lessons learned on how to coordinate around that, and our infection prevention and facilities work very tightly when there are potential outbreaks. And actually with measles, becoming a factor that we're worried about, there's been dialogue about what are we going to do the first time somebody walks into the emergency department and it's found out that they have measles because of the particular behavior of that virus. So I think it's a great question, certainly not something I thought about in medical school or residency, but something I think a lot about in leadership now.
Thank you. Okay, next.
Andrew Calick, City Club, you've all mentioned how you can leverage technology for the purposes of prevention. I'm also curious how you think about helping people maybe limit or manage their own technology use for prevention purposes. Some of the things you've mentioned, whether it's gambling addiction, social isolation, mental health, we see at least correlations with technology use from time to time. So I'd love to hear any perspectives you have on this as a prevention matter. Thanks.
So I'm going to start, but be very short in my answer. So I was an internal medicine doc quite some time ago, seeing patients one after another, not working in public health. And there are common conditions in adults. Congestive heart failure, sadly, is a common condition. Your heart fails. And when the heart starts to fail, fluid backs up and you start to gain water weight, which could make it even harder for the heart. Well, nowadays, speaking of technology, and I think it's fascinating, I wish we had it back when I was doing full-time primary care, people can wake up in the morning who have CHF and they weigh in, they get on the scale, and it is Wi-Fi'd to their provider, nurse practitioner, doctor, and they never have to go to the clinic. Somebody sees the weight, you gain 3 pounds in the last day or two, and you start to get a sense of, okay, we need to assess them, give them a call, are they having more shortness of breath? That's just a very simple Wi-Fi scale in the home that can really make a difference from a technological standpoint for early intervention.
Along the same theme of how does technology help us, if we think about assurance and trying to maintain access to primary care, there is an AI-powered dictation tool that our primary care doctors are sometimes using, and I was at my PCP this morning and he used it, and it listens to the visit and creates a draft note for them. That has been shown to increase retention, decrease turnover of primary care doctors nationally. So not the question that was asked, but I learned that statistic yesterday about retention, and I was so excited.
So I'm going to answer the question from a parent, family, adolescent space. So the message we hear is that technology is bad for adolescents, but it's a much more complex message. What we know in terms of preventative mechanism is parents. If parents are working with their adolescents, like on technology with them, monitoring what they're doing, the relationship between technology and outcomes for adolescents' mental health is moderated by that. So it's not that simple. It's not like amount of technology leads to adolescent poor mental health. It depends upon how they're using it, what they're doing, and most importantly, are parents engaged and involved and monitoring that behavior. So.
Dr. Vivek Murthy was in town a few years ago. I don't know if anyone here was able to be there for that, but he is very interested in this idea about social isolation and loneliness as one of those diseases of despair that we're seeing more commonly in the United States. And I do think there is a lot we need to be thinking about in terms of that and how we use technology. One of the things that we had talked about in public health is around disaster preparedness. One of the ways that we can be best prepared is to know our neighbors, right? So even as we're thinking about things like disaster preparedness, which is, making sure you have clean air filters or water or the food that you need for a disaster or medicine. What is really important is that you know your neighbors too and who's most at risk in your neighborhood. So as we're implementing programs around that, we're also thinking of that in terms of a type of intervention to reduce social isolation or loneliness too, especially in neighborhoods. We had been awarded an EPA grant that would also help support resilience hubs in 6 locations throughout Lane County. That work is now suspended while we kind of see what the outcomes of the EPA grant are, but that is the type of work that is funded in that kind of resilience building, emergency preparedness area, which is related to that work.
One other comment about technology too. I mentioned this in my talk, but in the work I do, technology increases reach and access to quality interventions for families in rural communities and underserved communities with very limited services. So yeah, I think it's not just a black and white picture, I suppose.
That's okay. That's okay.
Hi, Craig Opperman, City Club member. I just want to thank you all for the work you do and for being here today, and really give a shout out to Lane County Public Health, because I've seen and felt their work in our community. We're really lucky to have such a great public health team and leaderships. Thank you so much. And yes. And I have to highlight something you said, which is $1 invested in youth health, and I'd include behavioral health in there, the integration, social determinants, saves $16, which is such an important thing to have in mind as we look at how we manage the budgets. And so along with that, my question is, if you would talk a little bit about how the work is going in our community with coordinated care organizations, Trillium Community Health and Pacific Source, and I know you're involved with those. And then related to that, is there any discussion going on? You know, obviously Medicaid funding, there's more anxiety than ever. Are we doing contingency plans, or hopefully you can give us some reassurance, but what type of discussions are going on in terms of like frozen grants, or how will we keep up our health efforts if there's some uncertainty in our future? What's going on?
Oh, good question.
I'm happy to
Who wants to take that question? Be the first.
Thank you for the question. So I think in some ways we're quite fortunate in Lane County with regard to relationships with our CCOs. We have public health staff on the boards of both of the CCOs, and public health staff either supporting or on the committees and subcommittees. It's been that way since day one. August 1st, 2012 was the day Trillium CCO stepped up. I was on the board from that day one. I was on the board for 10 years, and we have other people on the boards now. When we got Pacific Source, January 1st of 2020, we have 2 senior public health people on the Pacific Source board, which is a great thing. The other piece I think that is unique, through a lot of hard work and a fair amount of luck, we get a source of funding for prevention, upstream prevention work from both CCOs that comes to Lane County Public Health. I must say, and I want Jocelyn to take it from here, this is something that the other 32 health departments really want to have. We get a lot of calls from the other health departments. How did you get that support for prevention from a payer of health care? Well, it's because, as was just said, you spend $1 and you're going to save 16. It just makes sense, and it also improves health.
Yeah, I could just say a little bit more about that prevention program that's funded by the CCOs. It really is unique in the country as far as I can see. It has been going on now for 10 years, and a lot of the programs are based in schools, which is that adolescent time period when we can really make an impact. I think one of the programs that many of you may be familiar with is Sources of Strength, and it is one of those programs. I'm sorry, I didn't say this is Jocelyn.
That's okay.
That is has a huge impact. It's not just suicide prevention, but has a lot of pro-social outcomes as well, and is really peer-led. So that's a really important aspect. But I do want to appreciate the contributions our local CCOs have made to prevention in Lane County. It really is unique.
And this is Kim, I just want to call out that, you know, from the hospital perspective, the interest of public health, the interest of our payers, whether it's CCO, the interest of the hospitals, the medical community, we have more in common than we have that is different. And a lot of times that's just about building the relationship, so I know who to call at each of those agencies or CCOs. And if I notice something with that group, we can have an open conversation. And if we just tell each other our stories, a lot of times we actually can get to common sense solutions. I do think it's a hard time, and I think it might get harder before it gets easier for the healthcare environment. I already mentioned that Oregon hospitals are in kind of a tough spot. We have the second lowest hospital beds per capita. That's really hard when we do have the worst flu hospitalization rate in 17 years this year, I think. For example, it really strains the system. So anything we can do with our CCOs or other insurers to say, make sure their insured clients are vaccinated, for example, helps them, helps us help the community.
Joel Corin, City Club member. I believe that it's been shown that vaccines help prevent disease. I believe that it's been shown that fluoridated water helps prevent tooth decay. There seems to be an attack on both vaccines and fluoridation, in addition to a whole lot of other stuff. How do you plan to respond?
Yeah, good question.
I can speak that from the hospital perspective, we will continue to prioritize through our hospital and our medical group all efforts to deliver evidence-based treatments, including prevention efforts like vaccines at every opportunity. I know, Joel.
Thank you all for being here. And I was really impressed when the COVID hit our community, how Lane County Public Health really got it together, and I want to thank you for that. My question is kind of related to the Lund report, where they talked about the hospitals not making money. And it seems to me they did mention, you know, how much insurance, commercial, what it's called, pays versus how much Medicare pays versus how the bottom line, and the bottom payer is Medicaid, as we know. But they did not mention administrative expenses. And I have heard in my career that administrative expenses are quite high. And could you kind of, either all of you or one of you, kind of let us know how much the administrative expenses are and why? Thank you.
I'm going first because I know very little about this topic. But I do know one point. When Trillium stood up, again, August 1st, 2012, we were looking at the administrative overhead that we as a board of directors would approve. And if you look at the national level, some payers is 20% overhead. If you get $1 million to give care to a certain population, they're going to take $200,000 right off the top to run the company before you're delivering any care. That's not the way it was for Trillium. We agreed to an 8% administrative overhead cost. That's a pretty lean organization. And I don't know what it is now. I'm not on the board anymore. Maybe Jocelyn knows, or maybe others on the panel know. But the CCOs are significantly leaner and provide much more money to direct care. And there's something called MLR, the medical loss ratio. By contract, at least 85% of all of the Medicaid dollars has to go to patient care. Now, oftentimes it's 90, 91, 92, 93, 94, but at least 85. So it's written in law, which is a great thing.
Thanks. I don't have a specific number to give you from the hospital's perspective on what River Bend's administrative expenses are, but I feel very qualified to speak to what part of the why. All of us would probably acknowledge that our American healthcare system, the current state, is not what any of us would have designed if we could start over. But I do see, I dealt with a situation this morning, again, before coming to this forum, that we had done an emergency surgery on a patient. The patient came in from someone's clinic for a procedure, had their procedure, went home. It was an orthopedic procedure. That procedure is on a Center for Medicare Medicaid Services list of only paid if it's for inpatients. So we delivered 6 figures worth of care to that patient, but they did go home within 24 hours. The surgeon treated it like an outpatient because they're going home so fast, doing so well. That means we don't get paid anything at all for taking care of that patient, whether it's for the nursing care, the cost to keep the lights on, the cost of the hardware and supplies used in the surgery to fix that patient's problem. That's not what any of us would want it to look like. And the number of people that have had to touch that record and the hours spent to debate this and what code and what's a reasonable next step is hours. That's my administrative expense that I looked at this morning that I thought, what a waste. This patient had an emergency. They could not go on like that. They had a good operation with a safe surgeon with a good outcome. They're better. And they don't want to pay us because it's on a list that says they should be only paid for inpatient status. Now, CMS is happy if we write a note in the chart that said the patient was an inpatient while they were in the building. That's ridiculous. So I'm sure there's hours we could spend talking about healthcare system design, but it's designed to have administrative expense excessively.
Paul, do you have a question?
I do. Paul
Good.
Thompson. I'm a city club member for a long time, decades. It seems like every moment of the day, we get a new revelation about what the federal government is doing in terms of cutbacks. And a lot of those cutbacks are indiscriminate. They're not particularly intelligently derived. I wanted to give you another opportunity to tell us what you think is going to be the place where these cuts settle out and you finally have a picture of how you can go forward in year 2 or 3 or 4 of the Trump administration. Thank you.
Good question. Who wants to start?
So as I mentioned, I work in the school space delivering mental health services to adolescents. A lot of adolescents would not receive services unless we connected with them in the school space. The cuts to school-based mental health services are very, very, very significant. And I anticipate that the mental health crisis we're experiencing now will only get much, much worse as these cuts take effect and have an impact. So, yeah.
This is Jocelyn with Public Health. I don't know. I'm not sure I can say. There is so much that is at play, and as you said, every day we get new announcements. Pat had talked a lot about the tobacco policy work that we do across all levels of public health, and the smoking and health office, for example, in the CDC has been closed. But what those trickle-down effects of some of the changes at the federal levels are really not clear yet at the local level. It's very difficult to say what the impact will be. We certainly are nervous, and many of our prevention programs are funded, braided with state and federal funds that come to us. So that includes suicide prevention and emergency preparedness and substance use prevention. So a lot of those programs are certainly at risk. And unfortunately, at this point, we really can't say what the impact will be.
We have 1 more minute left, so go ahead, go for it, Dr. Ruscher.
This is Kim. I just wanted to call out that in making these decisions of what we're going to be able to do, we have to go back from Peace Health of what is our mission and what is our vision for serving the community, and how can we provide as much care as possible to core areas of health and serving our mission and serving our community no matter what the circumstances are. And so that's how we're going to make decisions, is through our mission, and I think it's going to get harder before it gets easier.
Quick
All right,
response.
in 5 seconds, maybe.
5 seconds.
There's certain things we control and certain things we don't control. We do control some of the healthcare dollars. Medicaid, for example, is, depending on the state, is 60-40 program. The feds pay 60%, the states pay 40%. It's the biggest healthcare expenditure in the Oregon budget. We control that money. So we can control some things, and we need to focus on what we can control.
Thank you, everybody. Let's give it up for our presenters. Thank you so much. All right, Andrew.
This has been our May 9th, 2025 conversation at the City Club of Eugene. Next week, we will welcome leaders from the Oregon Country Fair to talk about the state of that beloved local institution and what we can expect this summer. One note, in addition, for City Club members, you will be receiving an electronic ballot on Monday morning with new board members and leadership nominations. Please check that out, fill out your ballot, and learn more about the amazing folks who are nominated to join the board this coming year. Have a wonderful weekend, especially you moms out there, and see you next time. Thank you.